joining us for today's VIA VitaFlow in association with you live webinar. My name is Michelle Harrington. I'm a registered dietitian on the Medical and Scientific Affairs team here at VitaFlow North America. We are excited to bring you this educational activity and introduce our speakers. Today's topic is pediatric nephrology nutrition for the non-pediatric nephrology nutrition practitioner, part 1. Please note this program is being recorded. Support for this presentation was provided by VitaFlow North America, a Nestle health science company. The views expressed herein are those of the presenters and do not necessarily represent Nestle's views. The material herein is accurate as of the date it was presented. It is for educational purposes only and is not intended as a substitute for medical advice. Please note that questions will be addressed following the presentation. However, you are welcome to submit text questions into the chat at any time during the program. Questions relating to product will not be addressed during this webinar. Feel free to contact your VitaFlow representative for product information following the program. I have the pleasure of introducing our speakers today. Kristen Kipper is an experienced dietitian, a certified specialist in pediatric nutrition, and has worked in multiple areas of pediatric nutrition at St. Louis Children's Hospital over the past 15 years. She spent the first 8 years of her career working in cardiology and has been working in pediatric renal nutrition for the past 5 years. Kristen also has several years' experience working for a national home infusion company, focusing on education to patients requiring home enteral nutrition. She is a proud St. Louis University alum. In her free time, Kristen enjoys spending time with her husband and her 2 active children. Rachel Damiani is a registered dietitian at Boston Children's Hospital. She has been working with pediatric patients with end-stage renal disease for the past 5.5 years. Rachel completed her undergraduate degree at UConn in 2014 and received her master's degree at the University of St. Joseph in 2017. In her free time, Rachel loves spending time with her family and her 1.5-year-old golden retriever named Piper. At this time, I'd like to hand it over to Kristen.
Thanks so much, Michelle. I'm going to go ahead and request control. I think we got it. It's a pleasure being here with everybody today. Rachel and I hope that we are able to kind of shed a little light on what can sometimes be an overwhelming and elusive thing when you get your first renal patient and you're not sure where to start. Okay, so our objectives today are first to describe 3 potential reasons for suboptimal linear growth in pediatric kidney diseases. Second, identify some clinical features of several kidney diseases, including autosomal recessive polycystic kidney disease, renal dysplasia, and hemolytic uremic syndrome. And then last, to discuss the nutrition priorities and management of those 3 diseases. Before we jump into those disease states, I wanted to just give a little quick background on some of the things we do when we assess nutritional status in pediatric kidney disease. I think the first thing to kind of look at that most of us probably look at is the patient's weight. With kidney disease, it can be a bit of a challenge to figure out weight trends, weight status. Our recommendation is to always try to estimate the euvolemic weight for any calculations. You could do this by base it on recent weight reports, also on hydration status. And then finally, if the patient is on dialysis or receiving dialysis, you can use post-dialysis weights. Kidney disease may lead to poor linear growth, and this is due to multiple reasons, as you can see listed there. It can be due to metabolic acidosis, inadequate nutrition, sodium depletion, renal osteodystrophy, or what we kind of call renal mineral bone disease, delayed sexual maturation, abnormalities of growth hormone, and then other micronutrient deficiencies, specifically zinc and copper. One of the attendings I work with has been known to frequently say the kidney does a whole lot that we just don't even know yet. So there are a whole lot of factors that we don't even know a whole lot about that are influencing poor linear growth. So our job is just to kind of take all of those things into consideration and know that the linear growth for kidney disease is probably not ideal. There it is. This slide is a little small and I apologize for that. The Pediatric Renal Nutrition Task Force came out with these recommendations in 2020, looking at a couple different sources of recommendations for calorie and protein needs in kids with kidney disease stage 2 through dialysis. So this chart is a really wonderful reference, especially with a new patient that you're not sure much about their history and you just need a place to start for recommendations. SDI stands for suggested dietary intake. So these kind of take into consideration the DRIs as well as what we know about renal disease. Reference is listed there below if you need to find it on your own. Okay, so getting into kind of the meat of some of our diseases here. First is renal dysplasia. Renal dysplasia affects 1 in 4,000 babies globally. It's a disease where the internal structures of one or both kidneys does not develop normally while a baby is in womb. It belongs to the spectrum of congenital abnormalities of the kidney and urinary tract. You can see there in the diagram, during normal development, 2 thin tubes of muscle called the ureters grow into kidneys and branch out to form a network of tiny structures called the tubules. The tubules collect urine as the fetus grows in the womb. In renal dysplasia, the tubules fail to branch out completely. Urine that would normally flow through the tubules has nowhere to go. And so instead it collects inside the affected kidney and forms fluid-filled sacs or cysts. The cysts then replace the normal kidney tissue and prevent the kidney from functioning. So it's kind of a multi-step process that basically leads to non-functioning kidneys. Some of the complications that occur because of renal dysplasia are hydronephrosis of the working kidney, meaning there's excess fluid in that kidney due to the backup of urine. Also, this can damage then the working kidney and therefore reduce its ability to filter blood. So you might have one kidney that has dysplasia, but because that one kidney has dysplasia, it ends up affecting and damaging the working kidney. Renal dysplasia also leads to frequent UTIs and hypertension. Some of the things that occur with renal dysplasia that are linked to worse prognosis for the patient are if the dysplasia is in both kidneys. If an infant is born with dysplasia in both kidneys, likely that they will need dialysis sooner rather than later. Many children can lead a relatively normal life if they have one dysplastic kidney. With renal dysplasia, you have decreased functional renal mass. So even if you do have one functional kidney, there is often decreased functional renal mass. A lot of urinary tract obstructions. And then finally, you can see the anhydramnios or severe oligohydramnios can occur also in the womb. Those are things that would lead to worse prognosis for the infant. As far as growth in renal dysplasia, kind of like I've already alluded to, most children with renal dysplasia have decreased height velocity for age compared to their expected for age. They also have decreased weight gain velocity compared to expected. We know some of the reasons why that might happen, and some of them I think we're still discovering some of the reasons that these growth velocities are impacted. Okay, so for the good part, how do you manage fluid and electrolytes in these kids with renal dysplasia? First, it kind of depends on whether either kidney is functioning. If you have one normally functioning kidney and the other is dysplastic, the patient's electrolytes might be normal and their kidney function, although not normal, might be good enough that there's really nothing you have to do differently for fluid or electrolytes. If both kidneys are dysplastic, that requires a closer management of what we're doing nutritionally. I would say first you want to manage the electrolytes by kind of monitoring phosphorus and potassium in labs, and then restricting the intake as needed. I'm going to talk about those values a little bit in a couple slides. The other thing you can do is manage fluid retention by restricting fluid intake. This has to be done in conjunction with your nephrologist and close monitoring of the urine output. Every patient's urine output can be slightly different. So normal urine output is based on, mils per kilo per hour based on the child's age. But sometimes you can have a normal urine output that might not be exactly reference, but the child is able to maintain their ins and out balance with their urine output being lower than reference. So I think that just requires a close following with your nephrology team to make sure that the INO balance is relatively even and that the labs are relatively stable at the same time. Okay, so I have just kind of an interactive poll question that there may or may not be an actual right answer. If you have a patient who is anuric or has decreased urine output, which of the following would you recommend? Oh, there it is. Thanks, Michelle. First choice would be adjust the fluid restriction, whether that's liberalize the fluid restriction or start a fluid restriction. Second choice, bolus with normal saline. Third choice, nothing, just continue to monitor. And fourth, discuss dialysis with a medical team. Give everybody a couple seconds or minute to put their choice in. Okay, there we go. Perfect. You can probably see those results up on your screen. Most of you chose adjust the fluid restriction, which is, and then I see second choice is also discuss dialysis with your medical team. Agree. I think actually given that very minimal information you had as your question, I think any of those choices may be appropriate. I think that adjusting the fluid restriction would be what I would work with first as well, depending on if the patient is already fluid restricted and depending on what their labs are, might kind of impact whether you're going to allow them a little more fluid or whether you need to restrict them a little bit further. So thanks for participating. Okay, so quick case study on a recent patient I've had with renal dysplasia. KF is a 14-year-old girl who presented in January of 2021. Just for reference, just not that we all have forgotten, but this was in the heart of COVID. So she came in with 3 months of fatigue, 2 weeks of upper respiratory infection symptoms, and had poor girl, repeated COVID negative swabs. She tested negative for all other respiratory infections as well. When she came in, her BUN was 154. For reference, normal for her age was 9 to 18, and her creatinine was 16.7. Again, for reference, 0.4 to 1.0. So she had severely impacted renal function. She had an abdominal ultrasound, which showed small echogenic structures in the expected region of the kidneys, which I always think that's funny when they say the expected region of the kidneys. It's bad when they're like, we can't even tell if it's a kidney. Likely representing severely atrophic and echogenic kidneys, which suggested chronic renal disease. So she was at age 14 diagnosed with renal dysplasia. This can be diagnosed at any time. It can be found on a 20-week ultrasound during pregnancy, or it might not be diagnosed until, like our poor patient here, until symptoms show up later in life. There it is. When she first came in, weight was at 41 kilos, or at the 8th percentile. I have her growth curve here in a moment, so you can see where her growth had been trending. And her height was 150 centimeters, or the 4th percentile. So she was a smaller size for her age. She was immediately started on a renal diet upon admission to the PICU, which I think occurred late on a Friday night when they saw her BUN and creatinine were what they were. That was interpreted by the attending team at the time as a low sodium and low phosphorus diet. The way our food service system works here, it doesn't restrict to a certain milligram necessarily, it's just low sodium and low phosphorus. She was started on hemodialysis, I think, within 1 day. They placed a line and started some hemodialysis pretty quickly. And eventually she was transitioned to nightly peritoneal dialysis 2 months later. She actually had a relatively short initial stay, but when she first presented, she had a really poor appetite. Partially, I think, because of her renal function being so impaired, but then also just general illness. She just did not feel well at all. She was on daily hemodialysis. We did not have her on any real diet restrictions because she was on dialysis 5 or 6 hours a day initially, I think 5 hours a day. But as she transitioned to intermittent dialysis 3 times a week, we started those diet restrictions, and I'll talk more about those momentarily. We transitioned then to PD as she became more medically stable, and those restrictions were a little bit liberalized then as well. She was managed on peritoneal dialysis at home for 6 months before she was listed for transplant. Our center here, we have a requirement that patients be medically stable on a mode of dialysis for at least 6 months before they can be evaluated and listed. She is very adherent and compliant and was doing super well on PD. So she was listed very quickly. And then she didn't have a long wait for a transplant. So she got a donor transplant in October of 2021. So from initial presentation to transplant was 9 months of a whirlwind for this family. She initially had a decreased appetite when she started peritoneal dialysis. Because she was 14, was able to tell me quite a bit. She mentioned that she felt a lot of abdominal fullness with her drain and fill of dialysis. As she got a little bit more used to that and adjusted, her appetite really increased, and she was able to eat a whole lot more. Our average wait time for a transplant here can vary. It can vary from weeks to months. Rachel, I know you probably can attest to the same. If you have a living donor, sometimes the wait is not long at all. Sometimes it's a couple months, especially for teenagers. It can be just a little bit longer too. But anyway, she was super adherent to the low sodium, low phosphorus diet. They were incredibly compliant. There we go. Yep. Her weight trend, you can see there. When she initially presented, she was right there at that red circle. So you can see her growth trend had really followed right along the 10th percentile weight for age from the time that she was a small child. So her growth really didn't indicate to anyone that she was having any issues. And when she presented, she was still right on her curve. She lost that initial weight when we started dialysis and pulled off a lot of fluid. She was transplanted at that green circle. So you can see even on dialysis, her growth curve really followed pretty well. Those subsequent points are since she's been transplanted. So with optimizing her renal function, you can see that her growth potential actually was probably just a little bit higher than it had been her whole life. Her height shows pretty similar. She was a very small child and continued to be small. But since she has been transplanted, she has gotten just above the 5th percentile. Her parents are also shorter individuals, so nobody was expecting her to be tall. Again, her linear growth probably was affected early in life by her renal dysplasia, but wasn't really noticed until she was diagnosed. So that's kind of it for the renal dysplasia for now. We can take questions on that later if we have time. Just a few slides on the hemolytic uremic syndrome. This is another renal disease that's most common in young children. It's when small blood vessels in the kidneys become damaged and inflamed, which can cause clots to form in the vessels. This can clog the kidney's filtering system and lead to kidney failure. Often, if you're inpatient, you'll see this often caused by E. coli. First symptom is several days of diarrhea, which is often bloody. It can be caused by other things, but I think what we'd see most common inpatient is that E. coli. Dialysis can be used as a form of treatment for HUS, especially for fluid management. I would say that using dialysis for HUS is very dependent on each individual patient, as well as your practitioners that are on with each patient. Factors that factor into whether dialysis is started here at Children's include the patient's energy levels, BUN creatinine levels, whether the patient is able to eat or drink, and just their overall fluid management and whether or not they're producing urine output. And most of our patients, when urine output starts to really drop off, is when we initiate dialysis of some sort until the urine output starts to improve. As far as the good part for us, the nutrition management, managing electrolytes and fluids. If we have a patient with HUS who is on continuous renal replacement therapy, or CRRT, those patients typically do not need diet restrictions with the T, so there's no need to restrict what they're able to eat. If the patient is on intermittent dialysis, these patients likely need sodium restrictions. I would say anywhere from 1,000 milligrams to 2,000 milligrams is kind of the norm. We do sometimes have patients that we have to do a 500 milligram sodium restriction on. And then also we use a fluid restriction to limit fluid retention. We usually use about 1 liter of fluid per day, but especially in small kids, we might go down to 500 milliliters a day for a fluid restriction. For patients that do not need dialysis to manage their HUS, those patients, especially while they're being critically or acutely managed, those patients are the ones that are going to need much more restrictive diets. So it might be the fluid and sodium restrictions we just talked about. These patients might also need short-term phosphorus and potassium restrictions depending on their electrolytes. How I often explain it to my coworker dietitians who are covering for me is the more dialysis they're getting, probably the less restrictions you need to use acutely. The less dialysis they're getting, the more restrictions they're going to need to be on until that HUS improves and their clinical status improves. Sodium restrictions, like I said, could be anywhere from 1,000 to 2,000 milligrams a day. Very rarely we'll go down to that 500 milligrams a day. That's like painful and almost impossible. Phosphorus restrictions, usually about 1,000 milligrams a day, and potassium restriction about 2,000 milligrams a day. Again, I think a lot of it depends on the patient's age, as well as how much they're really even eating. Some of these patients just feel so miserable that they're not eating a whole lot to start with, and they kind of are self-restricting on their own. As far as growth in HUS, long-term growth is not generally affected in these patients as long as their renal function recovers. Their linear growth does not take a huge hit from this kind of more short-term acute illness. Weight fluctuations are expected and common in HUS because their fluid status is changing. So you're going to have a lot of ups and downs. Often I try to not monitor growth trends for weight until they're out of their acute period, and then we can kind of start monitoring that weight trend a little bit more again. With that, I'm going to turn it over to Rachel for the other half of this presentation.
Right, so good afternoon, everyone. I am going to take over the second half of the talk, and we're going to continue on our progression of kidney diseases and talking first about posterior urethral valves. This affects 1 in 8,000 male births worldwide. It's a congenital malformation found only in males. The cause of PUV is unclear. There's potentially a genetic component, and research is ongoing. PUV is when there's extra flaps of tissue in the urethra that block urine from flowing out of the bladder. And there's a nice little graphic on the right that shows, what your normal, bladder looks like in normal kidneys. And then you can see with PUV that there, that extra flap of tissue, and you can clearly see that there'd be an issue with urine flowing out of the bladder. And like most diseases, there are varying degrees from mild to severe. And then when we think about some symptoms that our patients might experience with PUV, common symptoms include urinary tract infections. We see poor weight gain in infants, also painful or difficulty urinating. And some, the patients that I see, I only follow patients with end-stage renal disease, so kidney failure. So I'll walk through a case study of one of my patients who was premature, a 34 weeker. So 1 out of 7 means 1 day, 34 weeks in 1 day. So if you're new to pediatric nutrition, term is 37 weeks. He was prenatally dosed with PUV and bilateral renal dysplasia. He had a valve ablation, which is a surgical technique that will trim down the excessive tissue of the valves. It's a pretty minor and minimally invasive procedure. It just requires a small incision site at the removal of the valves. So while he was undergoing that valve ablation, he had a peritoneal dialysis catheter placed on day of life 11. Our typical practice here at Children's is to let the PD catheter heal for as long as possible. Our surgeons and nephrologists usually like to wait 2 weeks. They say the longer the better for the catheter to heal prior to using it, just to minimize any potential complications with starting PD. So in terms of, I know we're jumping right to his, discharge nutrition prescription, just due to time constraints, but his discharge nutrition prescription was a 38 calorie per ounce formula. Again, those new to pediatrics, standard infant formula in breast milk is estimated to be about 20 calories per ounce. So it's typical that our patients are on concentrated formula due to their fluid restrictions. 45 milliliters every 3 hours, so a total of 8 times per day. And at this point, he was taking 100% of his nutrition by mouth, no feeding tube necessary. The composition of this formula was a standard infant formula with added protein, carbohydrate, and fat powdered modulars. The modulars are nice because they don't really contribute to the potassium or phosphorus content. And because we are starting peritoneal dialysis, he actually has increased protein needs. And you can see that this is a pretty hefty nutrition prescription, about 138 calories per kilo. Our babies struggle to grow a lot. So this was kind of the best regimen that worked for him. And this is all based on his dry weight of 3.3 kilos. So to spend a little bit of time talking about dry weight, this is typically determined by the nephrologist. And I would say other team members definitely will contribute, especially our amazing dialysis nurses who are seeing our patients, every day, especially for our PD kids who are admitted to the hospital and getting PD every day. And it's the patient's normal weight without any extra fluid on their body. And it can really take several dialysis treatments and sometimes a month for our outpatient hemodialysis patients to truly determine what a patient's true dry weight is. So we're looking at their blood pressure. Are they hypertensive or are they hypotensive, meaning high or low blood pressures? If they're having high blood pressure, do we need to challenge their dry weight? We need to try to take off a little bit of extra fluid. Their volume status, so seeing if there's any edema or swelling on the patient, and also their respiratory status. So if our patient all of a sudden is developing an oxygen requirement or a higher oxygen requirement than normal, that might indicate that they have more fluid on and they might be above their dry weight. And I always like to say dry weight is an estimation. The E stands for estimation. So, we try to get this dry weight as accurate as possible, but sometimes we don't find out what their true weight is until they're transplanted and demonstrate their own growth without dialysis. So our same friend, 3 months later, as a reminder, he was discharged on a fully oral nutrition plan, which I would say is pretty atypical for the kids that I see. He was readmitted for a feeding evaluation and initiation of nutrition supports. At this time, an NG tube was placed just due to his faltering growth. The first arrow on this chart is his discharge from Children's about, after that prolonged 2-month admission since birth. The second arrow, the blue arrow, is when we admitted him for nutritional rehab. So you can see, he did do well initially with his weight gain, and then you see it start to plateau around months 4 through 5 of life. Our feeding team was consulted, which consists of speech language pathologists, and they cleared him to, start taking 10 nmLs per feed. He did have a swallow study that showed no signs of aspiration. We just wanted to rule that out. Limiting oral feeds to 10 to 15 minutes and monitoring closely for signs of symptoms of aspiration. They continued to follow him during his admission, and with ongoing input from the feeding team, we continued to, they recommended, slowly increasing the amount he would take by mouth for each feed. So close to the time of discharge, he was taking about 20% of his goal volume by mouth, with the remaining volume provided via NG tube. So at around 17 months old, he started growth hormone. And kind of as Kristen was alluding to, growth is a huge part of pediatric kidney disease. We know that growth impairment is a super common problem with our children with kidney disease. So growth hormone was started for this patient due to their suboptimal linear growth. He was averaging about 0.9 centimeters per month over the past 3 months, and goal for him was closer to 1.1 centimeters per month. His height for chronological age was more negative than 2 standard deviation scores. So the green arrow is when our friend started growth hormone at around 17 months old. As you can see from this growth chart, lengths and heights on young kids are extremely difficult to obtain. So I don't necessarily believe that he shrunk during any of these, but you can see that there are definitely some outliers on this picture. So since he's a dialysis patient, we comprehensively review all of our dialysis patients monthly, and growth is a part of that review. We noted a pattern of suboptimal linear growth trends and a decline in his height for EC score. So per the 2008 Kidoki guidelines, which is the reference that I use almost on a daily basis, they recommend growth hormone therapy should be considered in children with CKD. For their short stature, they say a height standard deviation score of less than negative 1.88 and potential for linear growth if growth failure persists beyond 3 months despite treatment of nutritional deficiencies and metabolic abnormalities. So we started the process of obtaining growth hormone, and unfortunately, insurance companies, they sometimes take a really long time to approve growth hormone in kids. So just because they write the script doesn't mean they start it the next day. It can sometimes take several weeks to start. And our little buddy received a deceased donor kidney transplant at, oops, I just inadvertently advanced, deceased donor kidney transplant at 2 years old. He was able to gradually wean off of formula in the outpatient setting post-transplant. So living donors will last about 15 years and deceased donors will last, 10 to 12 years. So kidney transplant is considered the best treatment option for children who have kidney failure. And the goal is to get these kiddos transplanted. One thing that people may be surprised to learn about for our pediatric patients who receive kidney transplants is that they're usually receiving adult-sized kidneys. So by the time they receive their transplant, it's usually after their first birthday or after they turn 1. There's usually enough space in the child's belly for a new kidney to fit. Our criteria here at Children's is they are obviously assessed by a surgeon to get cleared prior to transplant. Our surgeons really prefer them to be closer to 10 kilograms and about 65 centimeters long to make sure that there's enough space in the abdominal cavity to fit an adult-sized kidney. And then fortunately with our friend, we were able to wean off of formula altogether 3 months prior to his 4th birthday. And he did have a G-tube placed a few months after his kidney transplant, just for ongoing fluid and hydration needs. And at this point in time, his G-tube is only used for fluid and hydration. So you can see the green arrow is when he got transplanted, and dare I say he now has excessive rate of weight gain post-transplant, which is a whole nother talk for another day, but see growth definitely took off with normal kidney function. Moving on to FSGS. So this is a mouthful. So this stands for focal, meaning some, segmental, meaning sections, glomerulo, meaning of the kidney filters, and sclerosis, meaning scarred. So we frequently call it FSGS because it's a mouthful. So FSGS is one of the leading causes of end-stage kidney disease in children. It accounts for 7 to 10% of children with nephrotic syndrome. It's a disease in which scar tissue develops in the glomeruli, and the glomeruli are the tiny structures within the kidneys that filter waste products from the blood to create urine. So you'll see in this picture on the left, you'll see a healthy glomerulus, nice and red, healthy. You can see the blood impurities, are being filtered through urine output. When scar tissue develops with FSGS, you can see on the right side, you see the smaller filters, and the kidney function will decline. And this causes serious scarring, leading to permanent kidney damage. So a patient presenting with FSGS could have any one or multiple of these symptoms. So proteinuria, meaning the protein is spilling out into the urine. Edema, so this is retention of fluid, could be found around the eyes, the hands, feet, and the abdomen. High cholesterol, high blood pressure, elevated creatinine. So when those filters become damaged, the level of creatinine left in the blood will rise. And then low albumin, and this is just due to protein losses. So our treatment options for patients with FSGS are really dialysis and transplant. The kidney function will determine the need for a preemptive transplant, meaning that the patient does not need dialysis. They're able to go from having end-stage renal disease to transplant. And, having a preemptive transplant would mean that, the patient is cleared by all specialties and surgeon, and their kidney function is able to kind of hang on until they get their scheduled living donor transplant or deceased donor transplant. And we sometimes have patients that are able to, that need dialysis prior to going to transplant, just because their kidney function is declining faster than we can get a donor worked up, or if they're, if they're actively listed on the deceased donor list and we're still monitoring their labs, that they kind of, we'll call it tipping over, where they might need dialysis. And in terms of nutritional management for FSGS, a low sodium diet. So as I'm sure a lot of us know, that too much sodium in the diet can cause us to retain fluid and salt, and this could lead to edema or the swelling. And also it can lead to our volume status increasing, which could lead to hypertension or high blood pressure. Protein, so we're focusing on our lean proteins, and the protein is really dependent on if the patient's on dialysis or not. So our dialysis patients need more protein than other children of their age. In fluids, we usually defer to the nephrologist regarding the fluid provision. These patients might be prescribed diuretics to help them pee and regulate their volume, and they might be on a fluid restriction if they are on dialysis. Changing gears to talk a little bit about ARPKD, autosomal recessive polycystic kidney disease. This affects 1 in 25,000 children worldwide. I apologize for the typo, there should be one less zero. It's a genetic disorder with abnormal development of the kidneys and liver. And it can be diagnosed via ultrasound during pregnancy or soon after birth. This is when, during pregnancy, there might be fluid-filled cysts that form in the kidneys, and over time, more cysts appear, and they can also increase in size, making the kidneys much larger than normal, and it leaves less healthy kidney tissue to filter the blood. So these cysts are basically making the kidneys too big. In this diagram, it really speaks to, you can see from a distance, this individual, the kidneys look pretty small on the left, and you can definitely see the increase in size on the right for patients with ARPKD. I feel like one of the classic nutrition-focused physical exam things that we'll see with patients with ARPKD is their belly is extremely large, and their growth chart and their extremities look really small in comparison. And their growth chart actually might look what I'll call falsely good, meaning that like their weight gain and their height looks good, and their BMI might even say that they meet criteria for overweight or obesity. But then when you see the patient in person, you realize the weight is really in their belly, and it's their kidneys. It's not that they're really overnourished, because they'll have frequently leaner muscle mass on their arms. So this chart is an ARPKD inheritance diagram. I did not mess up on the spelling of kidneys. This came from the PKD International website, which originated in Switzerland. So that's why there's an A instead of E for kidneys. So you'll see that ARPKD will occur when a child inherits a faulty PKHD1 gene, which is the dark gene in this diagram, from both of their parents. So you'll see that for these two parents, they're both carriers, but their kidneys are not affected. And then if they were to have 4 children, one would be likely be affected by ARPKD, 2 would be carriers and 1 would not be a carrier. And what other problems does ARPKD cause? So we can see underdeveloped lungs, we see high blood pressure, eating difficulties. There's a lot of abdominal competition going on, urinary tract infections, liver fibrosis, and related problems. I've had a few patients that have actually needed to be listed for a combined kidney liver transplant due to ARPKD. And by age 10, about 60% of children with ARPKD will either need dialysis or a kidney transplant to survive. So it's pretty serious. We'll focus on another case study for my friend PK. He's a late preterm 36-weeker. He was prenatally diagnosed with ARPKD. On 2 weeks old, he was transferred to our NICU from an outside hospital. And 3 days later, he had a nephrectomy. So they took out one of his kidneys and placed a PD catheter. In comparison to our other friend who we waited to start PD, this patient started PD 3 days later as opposed to 2 weeks, just due to elevated BUN and creatinine. Just for safety reasons, the team decided that we needed to start PD sooner rather than later. So his dialysis was working really well for about 2 weeks, but then was put on hold due to his PD catheter leaking. So you could suspect that maybe this was due to not enough time for that PD catheter to heal and mature. And he ultimately went to the OR for a catheter revision. The surgeons found a lot of adhesions on the catheter. So his dialysis was restarted. His total fluids were restricted to 65 milliliters per kilo per day. Maintenance fluids for a normal healthy infant for this age would be about 100 mLs per kilo per day. He had a very prolonged hospital course that we won't have time to get into, but ultimately he did have another PD catheter malfunction and an omentectomy, which is the surgical removal of the omentum. And the omentum is a fold of fatty tissue inside the abdomen that surrounds the stomach, the large intestines, and other organs. So finally, we're talking about discharge. This mother was pumping, so we were able to utilize her breast milk, the breast milk being the most mineral friendly, and he was discharged in even more concentrated feeds than our previous friend that I talked about. 40 calories per ounce, so breast milk was the base, fortified with a standard infant formula, powdered carbohydrate and fat modular, and a powdered protein modular. He had a history of feeding intolerance, and just from spending so much time in the hospital, just kind of oral aversion and a little delayed with feeding. So working on continuous feeds due to vomiting and feeding intolerance. And the feeding team was consulted because based on his age, he was about at that age where we could start some purees and solids. So we focus on the trial of low potassium purees. So I agree totally with what Kristen said. You know, this patient's on PD, they're getting dialysis every night. Usually the more dialysis they're getting, the more liberal we can be and not as restrictive with their diet. For him, just because he was so fluid restricted, not very concentrated feeds, the team felt like it was the best just to start with low potassium purees and watch his lab trends. In terms of other nutrition management, my colleagues and I will typically say, you know, tastes of high potassium purees are okay in a small amount just for oral stimulation. But then this can also pose another problem, because if our patients really like that, you know, pureed avocado or those high potassium purees or bananas, then we feel kind of guilty taking it away. So we usually like to start with the low potassium if we can. So this is our patient's growth curve with ARPKD. So you can see on the left their weight for age and then their length. Again, definitely some outliers and definitely some copying and pasting of lengths across the board, because it is challenging to measure them. At 13 months old, he received a living donor kidney transplant. This patient is one of the younger patients that we've transplanted during my time here at Children's. As I mentioned, we usually try to ensure that the baby's around 10 kilos, and which is about 22 pounds. Our surgeons have just had experience with better outcomes the larger the abdominal cavity. So at 13 months old, we have now transitioned from our, renal cocktail, highly concentrated formula to a ready-to-feed age-appropriate formula. And over the past year and a half, post-transplant, we were able to wean off formula altogether. And we were able to do this in the outpatient setting. I'm lucky enough to follow my patients during their pre-transplant evaluations. They're on dialysis. I follow them during their inpatient admission and also in clinic post-transplant. The clinic frequency is very frequent when they're first transplanted, 2 times a week for the first 2 months post-transplant, then dropping down to once a week a few months later. At about 6 months, they're usually on a monthly clinic schedule, and then it spaces out to every few months. The further out they are post-transplant, the less frequently we see them unless there's other acute issues going on. So at this point, our friend is only utilizing formula when he does not feel well, has a sickness, or has repeated days of decreased intake. And these are the updated growth charts. You can see his weight on the left. You can definitely see excellent rate of weight gain. Right now, his weight, as of when I saw him in clinic a few weeks ago, he's at the 72nd percentile, and his height, you can see, is demonstrated beautiful catch-up linear growth post-transplant. His height's at the 82nd percentile, and his BMI is right at the 50th percentile, so growing beautifully. So at this point, we'll take any questions or feedback, and happy to chat more, make it as interactive as possible.
Thank you, Kristen and Rachel. That just was an amazing presentation. So yes, if people could put questions in the chat, that would be great. In the meantime, I do have 2 questions. I'll see what we get in the chat here. This could be answered by either one. For a patient with a prolonged hospital course, how often, or do you even recalculate that dry weight?
That's a great question. I feel like it honestly depends on the patient's age. So like for our newborns who we expect to be gaining maybe 25 to 35 grams per day, we could be reassessing on a weekly basis. And then I feel like for our older patients who maybe we expect them to gain 150 or 200 grams per month, we're reassessing it maybe a little bit less frequently. I had mentioned that we comprehensively review all of our chronic dialysis patients, both PD and HD patients, monthly. So that is like at a minimum that our team is reassessing our patients' dry weights. Obviously, if there's a change in clinical status where they're acutely ill and not eating or not getting goal nutrition through their tube for X, Y, or Z reason, that might warrant a more frequent reevaluation of their dry weight, because we anticipate that it probably is lower.
Thank you.
Yeah, I would say we do the same here. Exactly the same. Yeah.
We have a question from Linda. Linda's raising her hand. So I'm going to see if Linda, can you come off mute and ask your question?
For people who had to work this afternoon, is there a way to access this webinar at another time?
Oh, yes. So we record the webinars. So this will definitely be available in the near future on the VitaFlow VIA website. And then right afterward, I'm going to be sending you the slides as well as your continuing ed certificate. So yes, Linda, you can hear the whole thing.
Thank you.
You're welcome. Other questions? Angela is asking, do you monitor bone health in premature babies who require a phosphorus restriction? That could go to.
Yeah, I mean, we're constantly monitoring like calcium, phosphorus, PTH, or that parathyroid hormone level, and that 2008 KDOQI guidelines has a nice table of like recommended goal reference ranges for like what we would consider a normal or acceptable calcium or phosphorus or PTH. So bone health is definitely on the brain.
Yeah, always.
Okay. Do all infants with PUV require dialysis and transplant?
That's a great question that I'm embarrassed to say that I don't think I know the answer to that, but that is because I only follow patients who meet criteria for like stage 4 or 5 renal disease and like need dialysis or a transplant. Kristen, I'm not sure if you're able to better.
I'm kind of the same. I do think that ultimately they all do, but
Yeah.
it's how quickly, you know, some of their diseases are a little bit worse and they might need dialysis and transplant sooner. And I think some get to an older age before it's required.
Okay.
That sounds right.
Okay, here's a good question. I noticed that the formulas, whoops, hold on. Sorry, it moved on me. I noticed that the formulas are fortified with modular. So wondering if micronutrients are added somehow.
I feel like the ones that I'm using usually don't see other micronutrients affected as much. Obviously, you know, modulars are great, but also it's, you know, how much are we using them? If we can try to get away with using the least amount of modulars as possible, that would be great, just for simplicity of one, knowing what's in them, and then two, just for formula preparation at home for the families. We're trying to keep them on as a straightforward nutrition recipe and feeding plan as possible.
Is it
And we-
fair is it fair to say that you use like a standard formula and hit a threshold with a certain nutrient and then you kind of have to use modulars?
Yeah, I feel like it depends on the patient and what I'm trying to target the most, whether they're on dialysis or not. I'll frequently look at, like, you know, protein, potassium, phosphorus. Those are the big three.
Yeah. I also feel like, I mean, most of these kids are on a renal vitamin of some sort to help meet those other micronutrient needs too. But I agree, it's unfortunately so individualized depending on each specific patient.
I'm gonna just take this question though as an opportunity to tell you that Kristen and Rachel are coming back, and part 2 is art of pediatric renal formula mixing, because boy, is that not an easy topic. So please be looking for communications on that. We cannot wait. In the meantime, Kate has a question. For renal dysplasia, Kristen mentioned decreased functional renal mass worsens the prognosis. I'm not sure what is meant by that. Could you please elaborate?
Sure, yeah. So some kids have worse renal dysplasia than others. You know, more of their kidney is affected than others. So basically the slide probably wasn't very clear, but the worse each kidney is affected, you know, the worse the prognosis is for the patient, meaning the sooner those kidneys are going to fail and the sooner they're going to need dialysis or transplant. Does that make sense?
Yeah, great. Thank you. Okay, so back on the formula, a comment. Just thinking if you are doubling the calorie level, you would be using half the formula volume.
Oh, as far as like mixing the powder.
Wow.
And I guess concentrating.
Yeah.
Yeah. You're not wrong.
Nope.
Okay, Anne-Marie would like to know, how concentrated can a formula for a 3-month-old baby be? I saw you use protein modular. Is that too soon for an infant this age?
Yeah. I've taken care of some really sick babies, and, you know, unfortunately, especially if they're PD catheter, if they need dialysis, their PD catheter is placed. We're trying to live by without dialysis for 2 weeks. The team is then further restricting fluids than what they normally would be on if they were on a full PD prescription, adequate PD. I've concentrated pretty high. And usually everyone's like, what about tolerance? And it's kind of like, if I'm being told by the team I only have so much fluid, that's how I get to that calorie goal. I don't just wake up one day and say, this baby looks like they need 40 calorie per ounce formula just for the fun of it. Obviously, it's a very fluid, no pun intended. You know, as soon as we're able to liberalize fluids, we can back down on the concentration. I would say our NICU, you know, we do use the powdered protein modular. And yes, could technically be used like off label. There's just takes a lot of time to get things like officially, I should say, like recommended, you know, FDA regulation for things for infants or pediatrics in general, but then under the age of 1, it's a lot of time and money.
Yeah, and I agree. And it's not always using, you know, for an older kid, you might use X numbers of scoops of the powdered protein modular. Instead of doing that, it might just be like 2 grams, or, you know, it's not always what we would use in normal sizes for older kids.
Great, thank you. Jessica is asking, do you have a, air quotes, go-to nutrition prescription for babies with congenital nephrotic syndrome, specifically for hypertriglyceridemia?
Ooh,
I
good one.
personally don't. I feel like a lot of it is medication management. It's an unfortunate, you know, known problem with nephrotic syndrome. If there would be a renal-friendly formula that could also target hypertriglyceridemia, that would be fantastic.
Anne Marie says thank you. Keep the questions coming. We're going to probably do 1 or 2 more. A question for Kristen. This is around when you were doing sodium restrictions of the 1,000 milligrams, 2,000. Is that basically we get that from the diet? That's like our allowance, or do we have to take into consideration anything else?
You know, that's a great question. If it's an inpatient who's kind of being acutely restricted, we usually just kind of look at the diet. I'd say, though, if it turns into a longer term situation where we really need to follow that sodium restriction for other reasons, then yeah, then I'm looking sometimes at medications and fluids and anything that might contain sodium. Yeah.
Right. Gotcha. Okay. This is a last call. Anyone? We have maybe another minute for 1 or 2 more, but okay, I don't see any more questions. So at this time, I'm just going to say thank you again to our presenters. Thank you to the audience for attending, joining us today, and for your participation. Like I said, Kristen and Rachel are going to return. We're going to have our formula mixing, rationale, all kinds of tips webinar next. And again, if you could just please look for your continuing ed certificate as well as the slides in an email from us. And then this will be posted on the VIA site so you can watch it in its entirety in the very near future. So thank you on behalf of VIA, VitaFlow in association with you. We certainly hope you found this webinar helpful to your practice, and we hope you have a great fall day. Thank you.
Thank you, everyone.